oncology, neurosciences, gastroenterology, orthopedics, and more. Powered by advanced technology, our 21 operating theaters, including hybrid OTs, 5 surgical robots, and a 3T MRI, enable precision in even the most complex procedures. A trusted destination for complex transplants and advanced urology with minimally invasive Resume water vapor therapy. And a dedicated urology lounge with on-site recovery and physiotherapy. Even after you return home, your journey with us continues through virtual follow-ups, ongoing specialist care, and support without borders, because we're designed to bridge the distance. When you choose Manipal Hospitals, you choose a destination trusted by patients from around the world for expertise, innovation, and compassionate care. So, for anyone, what begins with a search transforms into a lifetime of trust and care that always feels like home. Manipal Hospitals, a name you can trust. For more than 3 decades, one name has always been trusted when it comes to healing. Across the city, country, and across the world. Manipal Hospitals, Old Airport Road. A center of healthcare excellence built on knowledge, precision, and human-centric care. A place where 1 million lives have been touched and the world has come to trust. Every year, thousands of patients across the globe choose Manipal International Patient Care, the global gateway of Manipal Hospitals, India. It begins with a search and the Golden Pass. Manipal Hospital's exclusive healthcare concierge program for international patients. A single-window solution designed to simplify every aspect of medical travel. From medical documentation to visa assistance and embassy coordination, every step is managed by a dedicated team. A completely paperless pre-arrival experience. From the moment you arrive, everything is taken care of. Airport pickup, quick access to a doctor, and someone to guide you through each step. Our International Patient Center is designed around you. From the moment you arrive, every detail is thoughtfully taken care of. An exclusive lounge, multilingual support, familiar cuisine, travel and stay arrangements, insurance and forex assistance, and seamless care before, during, and long after your visit. So wherever you've come from, you never feel far from home. Prime access at Manipal Hospitals prioritizes your journey, fast-tracking consultations, investigations, and treatment from the very start. Admission to inpatient rooms which are built for comfort, calm, private spaces for rest and recovery. Here, you experience world-class clinical strength, backed by multidisciplinary expertise across cardiac sciences, oncology, neurosciences, gastroenterology, orthopedics, and more. Powered by advanced technology, our 21 operating theaters, including hybrid OTs, 5 surgical robots, and a 3T MRI, enable precision in even the most complex procedures. A trusted destination for complex transplants and advanced urology with minimally invasive Resume water vapor therapy. And a dedicated urology lounge with on-site recovery and physiotherapy. Even after you return home, your journey with us continues through virtual follow-ups, ongoing specialist care, and support without borders, because we're designed to bridge the distance. When you choose Manipal Hospitals, you choose a destination trusted by patients from around the world for expertise, innovation, and compassionate care. So, for anyone, what begins with a search transforms into a lifetime of trust and care that always feels like home. Manipal Hospitals, a name you can trust.
Yes, good evening, everyone. Give us about 3 minutes and we start. Thank you.
Good evening, Greg.
Good evening, everyone. Dr. Mallikarjun here. So, whenever you guys are ready, we'll start.
You're so much welcome, Doctor. We are going to start in about 3 minutes.
Sure, Doctor.
Oh, yes, Dr. Yes, Dr. Drake. I think you have quorum. We are more than 50.
Okay.
So we can start.
Okay, thank you, Dr. Sechandri. Just 2 minutes.
For more than 3 decades, one name has always been trusted when it comes to healing. Across the city, country, and across the world. Manipal Hospital's Old Airport Road. A center of healthcare excellence built on knowledge, precision, and human-centric care. a place where 1 million lives have been touched and the world has come to trust. Every year, thousands of patients across the globe choose Manipal International Patient Care, the global gateway of Manipal Hospitals, India. It begins with a search and the Golden Pass. Manipal Hospital's exclusive healthcare concierge program for international patients. A single window solution designed to simplify every aspect of medical travel. From medical documentation to visa assistance and embassy coordination, every step is managed by a dedicated team. A completely paperless pre-arrival experience. From the moment you arrive, everything is taken care of. Airport pickup, quick access to a doctor and someone to guide you through each step. Our International Patient Center is designed around you. From the moment you arrive, every detail is thoughtfully taken care of. An exclusive lounge, multilingual support, familiar cuisine, travel and stay arrangements, insurance and forex assistance, and seamless care before, during, and long after your visit. So wherever you've come from, you never feel far from home. Prime Access at Manipal Hospitals prioritizes your journey, fast-tracking consultations, investigations, and treatment from the very start. Admission to inpatient rooms which are built for comfort, calm, private spaces for rest and recovery. Here, you experience world-class clinical strength, backed by multidisciplinary expertise across cardiac sciences, oncology, neurosciences, gastroenterology, orthopedics, and more. Powered by advanced technology, 21 operating theaters, including hybrid OTs, 5 surgical robots, and a 3T MRI, enable precision in even the most complex procedures. A trusted destination.
Displaying, we can start. Yes, thank you so much. Good evening, good afternoon, good morning, everyone, depending on where you are. You are so much welcome to today's Uganda Medical Association CPD series. And on this important topic of bone marrow transplant and CAR cell therapy, we are so much grateful to Uganda Medical Association in partnership with Manipal Hospitals for giving us this opportunity to have presenters who are senior consultants in this to help us break down this topic and also continue to lead us in knowing how best we can approach patients of this nature and how we can get super specialized services even that are not available outside here in Uganda that we can. One is Dr. Marikajun Karasheti, who is a head of department and senior consultant of clinical hematology and hemato-oncology and a bone marrow transplant
For complex
at Manipal Hospital. A little about his profile. Yeah, just a minute. It's a lot, but I'll say something small. He has a total experience of 21 years as a medical practitioner and 11 years as a specialist in hematology. He established stem cell transplantation and clinical hematology programs at HCG Cancer Center. His field of expertise is in bone and bone marrow transplantation for both benign and malignant disorders. He's a fellow of he's a fellow of BMT at Vancouver General Hospital in Canada. He's also a fellow and a member of DM Clinical Hematology at Seth GS Medical College and KEM Hospitals in Mumbai, India, and is a founder of BMT and Clinical Hematology Program at HCGMSR, Bangalore, India. He has a lot of achievements and a lot of publications that he has done and achieved. Kindly welcome our senior presenter, Dr. Markajun Karashet. The co-presenter is Dr. Francis Sari, one of the Uganda's most accomplished clinical hematologists, physician scientist, and HIV researcher. He is a deputy executive director at Joint Clinical Research Center here in Uganda. He's a lecturer and trainer in HIV medicine, internal medicine and hematology at Makerere University College of Health Sciences, and is a faculty member in the Hematology and Oncology Fellowship Program at Uganda Cancer Institute. He attained his medicine and surgery degree from Makerere University and a Master of Science in Clinical Hematology from McMaster University. And he also has a lot of other additional qualifications. So, ladies and gentlemen, receive our presenters for today. We shall have Dr. Francis Sali first, who will give us an overview of how it is in Uganda. And then after that, we shall listen to Dr. Karasheti. You're so much welcome, Dr. Francis Sali. Thank you.
Thank you very much. Good afternoon, everyone. I'll use a few slides to illustrate some of the issues. I will do some basic introduction because some of the people on the program may not have seen bone marrow transplantation. And I've also borrowed some slides and also made some. So the definition and goals of bone marrow transplantation is, it has been around for some time, since the 70s, and it is able to cure a number of blood disorders. Most of them, let me see if I can put my face there. I don't know, can. So, so it is used to treat a number of disorders, both benign and malignant. And the bone marrow transplants are generally divided into two types. There is the autologous, where you use the patient's own cells to do the transplantation, and also the allogeneic, where you use cells from somebody else. The autologous is like the transplant that was recently done at the Cancer Institute for a patient with multiple myeloma. So all these transplants involve, collecting cells, then giving the patient some form of chemotherapy. And the purpose of that chemotherapy is, one, to deal with the primary disease in most instances. Number two is to create space within the bone marrow, and also to create tolerance to the graft that the patient is going to have. The autologous, as we said, those are using someone's own cells. The allogeneic, we use cells from somebody else. Uniquely, if we have to use cells from someone else, we have to type the cells to make sure that the the HLA proteins on these cells or between the donor and the recipient, that there is a match. And we look at both HLA class 1, looking at HLA A, B, and C. We do both 2 alleles on each. And also we use the class 2 HLA. We do HLA-DR B1, HLA-DR B2, HLA-DQ B1, and HLA-DP B1. And if there is not a complete match, like maybe a 12 out of 12 match, or 10 out of 10 in some centers, then we can do what we call donor-specific antibody testing. We check if the recipient has some antibodies that can cause rejection of the graft. And then if we also use cells from somebody else in this, which we call the allogeneic bone marrow transplant, we have to do some treatment to prevent graft versus host disease. We call this graft versus host prophylaxis. It may come in different forms. Sometimes even after you've done it, patients may still get graft versus host disease, which may be acute or chronic. So conditioning is the sort of treatment that someone undergoes to prepare them to receive the graft. It varies in the medicines that are used in the conditioning, and also the intensity with which these medicines are used. The most intense form is called myeloablative, where you completely destroy all the cells within the marrow. There is no chance that the patient, his or her cells can regenerate in any way after you've given this treatment. So they will entirely rely on the graft. And also, then on the lowest end is the non-myeloablative. And then in between there, now there's also the reduced toxicity conditioning, which is myeloablative, but is not as toxic as some of the conditioning that were used before. And you will hear about engraftment. And engraftment, we talk about the neutrophils, how they sprout, if I may say that. And once you get a count of above 0.5 to the power 3 per microliter or to the power 8 per liter, then you are good. The risk of bacterial infections, neutropenic, febrile neutropenia really goes down at that point. And for platelets, if they're above 20,000 per microliter, without any transfusions or on 3 consecutive measurements. So there are various types of sources of the stem cells. I think up until recently, most of the graft are directly from the bone marrow. That means you poke the marrow in theater, do a sufficient aspiration, and this is calculated. The cell dose is calculated based on the patient's weight, and also the peripheral blood stem cells. More recently, I think there are more centers that are using peripheral blood stem cells. These ones, we use an apheresis system, and we have apheresis systems now here in Uganda. The other one is cord stem cells, but I know that most centers don't do cord stem cells because the cell content, stem cell content is usually relatively low. And so it takes a bit longer for the marrow to engraft, and so the patient is exposed to more risks of infections during that time. The peripheral grafts are much easier to perform. but they also carry a high amount of lymphocytes from the donor, and these increase the risk of graft versus host disease. But the advantage is they tend to engraft much earlier and then the bone marrow, and also to the donor, it is, it doesn't involve being in theater, doesn't involve any anesthetic, can come and donate and go home that very day. Examples of the autologous bone marrow transplant, for instance, in multiple myeloma, this autologous is now being used as a standard part of consolidation therapy. I think we are now, since we've started having this in Uganda, we're going to see lots more of this autologous transplants in multiple myeloma. They're a little bit easier than the allografts, and I'll briefly mention about that. And also, they're also used in some of the relapse lymphomas that are still chemosensitive, some of the relapse Hodgkin, relapse diffuse large cell lymphomas, some of the primary mediastinal lymphomas, and even mantle cell lymphomas. But these are the commonest. However, the list is a bit longer. This is it's just a schema, just gives you an idea. Like say if we are doing a multiple myeloma patient, we give them filgrastim to stimulate their marrow to make more stem cells. And after a couple of days, by around day 4, day 5, we check to see whether they have enough cells, and then we can harvest them using an apheresis platform. Some centers use another medicine, which we don't yet have here in Uganda, which is plerixafor. Basically, it causes it, goes to these molecules, the CCR4 that anchor the stem cells in the bone marrow, and they cause them to be released, and then you get a more successful harvest. And then the patient undergoes chemotherapy, usually quite a high dose of melphalan. The dose may be adjusted based on the patient's kidney function, but if it's okay and the patient the age is not too bad, he can have the full dose of it, 200 milligrams per meter squared. And usually within, 18, 24 hours, the melphalan is gone and they can have their stem cell infusion. In this case, the stem cells do not require any cryotherapy. They can actually be kept in the fridge for that short period of time, and success is good. The other, which we are also going to do here, is the autologous stem cell transplant for the lymphomas. And those ones, mostly there is a chemotherapy called BEAM, which, as you see in the chart, has camustin, etoposide, melphalan, and cytarabine, and they're used in that combination to, first of all, the patient's stem cells are collected, they're mobilized, more or less similarly to what you saw in the myeloma stem cell mobilization. And once they are harvested, they are then stored, they are cryopreserved, because you can't keep them in a fridge or at -70 for that time. So they are cryopreserved in liquid nitrogen. And then the patient undergoes the chemotherapy. And once that is done, then they can have the stem cells infused. So these are the more extensive indications for autologous transplantation. There are many, but what I mentioned above, I think, are the ones that will be keenly of interest to us here in Uganda. Then the allogeneic bone marrow transplants, these can be grouped into the related and unrelated. Here in Uganda, we plan to do mostly the related ones. The unrelated require require a donor bank where you can approach, we can check a donor register, and so that you can be able to check if there is somebody who has an HLA match with the patient. But in Uganda, we do not have a donor register. Maybe that's something that will develop in the future. And in the related ones, we can have a full match, and usually that is from a sibling from same parent, same parents. We don't have so much consanguinity here in Ugandan societies, so we will look for the matched donors mostly in the siblings. Then the haplos can also still, haplo meaning a half match, can be, yes, they can be from the parent or from the sibling. Syngeneic is if you have twins, which what do you call those twins which are, you know, very not the ones which are different, but the ones which are very, very similar to distinguish from
identical.
The identical twins, yes. So the unrelated, we are not going to do so much of the unrelated for now, but these are done in some of the other countries, especially for some of the malignant indications, and also for some of the benign. We haven't seen good success between for sickle cell disease in those patients who have had allografts from registries in other countries. They tend to, even if they are full HLA matched, they tend to have a lot of chronic GVHD, and I think most centers are going away from that for sickle cell disease. The other one are the cord stem cells. They tend to accept the patient, the recipient. The risk of GVHD is much less. It's just the numbers of these cells, and in some countries there are some technologies to expand these cells before they are given. But I think for now we are not going to consider the cord stem cells here in Uganda. And there are quite a number of indications for allogeneic bone marrow transplants. In most countries, there are malignant conditions, but which in our case is going to be largely acute myeloid leukemia that is not, that either has relapsed or where there is some measurable residual disease after completing therapy. So those are the sort of malignant conditions where we are likely to, where we plan to do the allogeneic transplants. But the largest number of allogeneic transplants is going to be the sickle cell, because Uganda, as you know, is like number 4 or number 4 in terms of prevalence of sickle cell disease, and in the whole world it is number 5. So it's, for us, it's a big issue. We see some patients occasionally with aplastic anemias, and I think once we start the more extensive transplants, we may see also some patients with congenital immunodeficiencies. Some of these patients are missed. There is timeliness with which one needs to refer the patient for transplant, especially for the congenital immunodeficiencies and some of these inborn errors of metabolism, before the patient has extensive damage. In terms of assessments that we do before considering to start the patient in the process of transplantation, either through referral or consideration, of course, the primary disease is very important. The pre-existing infections, screening for them, things like CMV, which have high impact on the transplant outcome, and also organ function in the individuals and the mental status. But also, more importantly, also if a patient does not have sufficient social support, does not have an attendant who's reliable, who will support their care after, it may not be worthwhile going through that transplant because it's quite a stretch. Usually patients are not back to their normal life for a whole year after the transplant, except for the autologous. Autologous recovery is much, much faster. And I mentioned something about the conditioning. These are the sort of the treatments which largely comprise chemotherapies and some immunosuppressive or immunomodulative medicines. So which are done before the actual transplant. So the underlying disease is paramount. It determines what sort of conditioning one will need. If, for instance, you are treating someone with a transplant, say for acute myeloid leukemia, will need to really empty that bone marrow, so they will get what we call a myeloablative, conditioning that will wipe out all the cells. So the treatment goal is very important, and also the transplant type, whether it is allograft, whether it is it's autograft, and also the sort of the source of the stem cells, and if, for instance, as I mentioned, one is using cord stem cells, the likelihood of the intensity with which one uses prophylaxis for graft versus host disease is very different from say, if one uses peripheral stem cell source. So the other aspects are the HLA, how matched they are, the ABO group. Sometimes if there is ABO mismatch, which is likely to give either major or minor mismatch, patients also may undergo other additional treatments like either plasma exchange, or they may have medicines like rituximab, which tends to knock down B cells. So the treatment may be a little bit different. Or if the patient has donor-specific antibodies, they may need exchange of their plasma before the actual transplant. And the other thing is, of course, the patient's condition, performance status, the age. If you're dealing with a very young child, you wouldn't say like to use conditioning that has radiotherapy, for instance, because that young child may not be able to, it may be more harmful to that individual. And also other things like path therapies and comorbidities that might impact on ability to use some of the conditioning regimens. I give you this, these are just some examples. For instance, in this for sickle cell disease, these are some of the conditionings that we have planned. One of the medicines that we use in myeloablative treatment is busulfan. And if we use busulfan, the less toxic approach to using it is to use it with fludarabine rather than with cyclophosphamide, and also using antithymocytic globulin. So in some cases, if it is a matched sibling donor, we may actually even eliminate the fourth dose of methotrexate after the transplant. So after the transplant, we give them cyclosporin and then methotrexate as part of the GVHD prophylaxis. This more increasingly, we didn't have this drug. It is very expensive. But we know that in India there are generics of treosulfan than if we used busulfan. So we are likely to get treosulfan and to replace busulfan and use it with thiotepa as one of the regimens. Now, in Uganda, we do not yet plan to do haplo bone marrow transplants. We want to make sure that at least the community or the society is very comfortable with the outcomes of the matched sibling transplant. So, in all probability, we are likely to refer the individuals who need transplant, but they have a half match. And I'll briefly mention why that might be important. Is because the haplos, the conditioning, the prevention for graft versus host disease is rather different. This is one of the common conditioning that is used using thiotepa, low doses of cyclophosphamide, anti-thymocytic globulin, fludarabine, and about 200 centigrade of total body radiation. Some centers use 300. And then the unique issue about the haploidentical transplant is that they use post-transplant cyclophosphamide, 50 milligrams per kilogram per day on day 3 and day 4 after the stem cell infusion. And then on day 5, they start the mycophenolate and either sirolimus or calcineurin inhibitor. There's no big difference there whether they use sirolimus or tacrolimus or cyclosporine. I think here we plan to use mostly cyclosporine. So this is about the same. If the patient has donor-specific antibodies, as I mentioned, the conditioning becomes a little more complex. You have to do plasma exchange earlier on before you start your conditioning therapy, giving them rituximab, which is a monoclonal antibody that knocks down the B cells. It's an anti-CD20. And then they're given some IV immunoglobulin to dilute the effect of the donor-specific antibodies before they go through the conditioning. And some centers also use buffer coat infusion. This is more traditional, but maybe it might not be very, very necessary. Here at our center, we are setting up a BMT
Dr.
unit.
Sari, you have about 5 minutes. Thank you.
Yeah. We are setting up a center with 6 beds, which are positive air pressure with HEPA filtering, and our design, unlike other centers where you may separate the BMT unit from the ICU, our rooms are designed to do the full pack, including the ICU care. And platforms that are available for collecting stem cells in case we use peripheral blood collection. The same platforms that are used for plasma, for red cell exchange, for apheresis are available in the country. And irradiation, there's no way you can do transplantation, allogenic transplantation, without doing blood irradiation. So we already have the blood irradiators in the country. And also we have set up capacity for liquid nitrogen storage and a lot of microbial support. Post-engraftment, we have a number of patients that have had transplantation from other countries, and the intensity with which they are followed up varies depending on the complications they have and the day from the time of transplant. Most of these patients, we get them after day 100, after they have gone a little bit beyond the period of acute GVHD. But we still do get a fair amount of GVHD in these patients, and infections. Infections are one of the major killers of patients. And this is US data, but you can see that where they transplant mostly for malignant disorders, but you can see that infections are quite a big issue, both for the adult patients and the pediatric. I'll briefly mention in the last 2 minutes on gene therapy. We're already setting ourselves up for gene therapy. We've trained and we continue to train the workforce for that. And we got some products that we can potentially use. And also we have the platforms for cell sorting. So in gene therapy, we use the same cells from the same patient, and we collect them using that afresh platform. In our lab, we already have the CleanMax platform that can sort stem cells. Right now, we are doing a study using cord stem cells and just manipulating them in the lab to see our transduction success rate. But patients, this is what they will undergo. Once those cells are collected, they are going to be processed. We've got some partial funding from government. We hope that once we get more funding, maybe by next year, we should also be able to set up the lab fully to support the gene therapy part, a clean GMP lab. And once the cells are processed, they are cryopreserved, the patient goes through chemotherapy, and then the cells are infused, more or less like what you do for an autograft, like almost like a myeloma autograft, and then they get their cells back. Where that has been done before, success rate is better, is good, and patients, especially for sickle cell disease, they do quite well. So we think that will help a number of patients. Currently, that treatment is very expensive, but when we start manufacturing it here locally, we think many patients are going to access it. The cost should come down by more than tenfold. That's our goal. So thank you very much. I'll stop here.
Wow. Thank you so much, Dr. Sari, as a person and also JCRC for the advancements in technology that you're bringing nearer to us. And we believe over time, services will get much more better for the benefit of our citizens here in Uganda. Thank you once again, and may God bless you. We kindly request that you stay online because we have a session for question and answer, and we have questions that are directed towards you.
We'll be able to get
treatment. Thank you so much.
Yeah.
Thank you. We are now welcome Dr. Karasheti. Dr. Karasheti, you're welcome on board.
Thank you.
To give us what happened in India. Thank you so much, Doctor.
Thank you. Let me share my slides quickly. Good evening. So my slides, are they visible?
Yes.
Okay. All right. So first of all, thank you.
Yes, Doctor, they are.
Thank you. I want to start by thanking Dr. Francis for this wonderful lecture. Really, so he's done most of what I would have done in the bone marrow transplantation part of the lecture. So I'll quickly run through the slide. Perhaps I'll touch a few slides on the CAR T cell therapy. I hope they are in the slide mode. So thank you for being here, and thank you all of you for joining and for this opportunity. Really, a few slides of our Manipal Hospital. The slides are in the slide mode, full screen you can see, or are you seeing multiple slides?
Dr. Karashet, they are not in slide mode. Kindly put.
They're not in the slide mode. Hold on, please. Let me use. How do I do that? Slideshow. Now they are in the slide mode, right? Yeah.
Yeah.
Yes,
Okay.
yes, doctor.
Okay, so we are a quaternary care center in Bangalore, south part of India, Karnataka. We have comprehensive teams for almost all specialties, including the heart transplant, the lung transplant, the kidney transplant, the liver transplant, and oftentimes the dual transplant. We are one of the oldest hospital network in the country, and we not only cater for the Indian patients, but for from across the globe, and for right reasons. So I'll quickly go to our topic, the hematology, oncology, and cellular therapy. We're part of a comprehensive cancer care, where there's a medical oncologist, there is a hemato-oncologist, the radiation oncologist, the surgical oncologist, and of course the evolved blood bank system. We deal with the pediatric and adult patients for acute leukemia, chronic leukemia, myeloma, lymphoma, Hodgkin's and non-Hodgkin's, almost all of them. And we have transplantation and CAR T cell therapy being done in a hospital. We also have the teaching programs for the subspecialty of hematology, oncology, bone marrow transplantation, and radiation oncology. That kind of helps us in involved in the teaching too for these patients. So that is about our hospital and our specialty. So the comprehensive cancer care center has to have all the specialties evolved, and that makes our job much easier. When you need to cross consult with any team, they're easy to get to, and to help us in necessary. So I think bone marrow transplantation is largely kind of touched on most of the topics. We all know the tragedy that struck on Hiroshima and Nagasaki way back in the World War, which killed instantly 90,000 to 120,000 people because of those bombs. But what it also showed was, amongst the survivors, one of the things that was seen is that the bone marrow is extremely sensitive to radiation, and that it can also be repopulated with the stem cells. So this particular observation led to development of radiation as a part of conditioning protocol. I do not know how many of you actually follow Bollywood. So this is one Mr. Amitabh Bachchan, who is called as the big B of Bollywood. And we know who is the big D of bone marrow transplantation, Sir Donald Thomas, who actually, after several years of bench to bedside research on the bone marrow transplantation, did the first bone marrow transplantation way back in 1950s. And well deservedly, he was given the Nobel Prize for his relentless work with his wife in the field of transplantation, which now saves thousands of patients across the world, really, who otherwise would not survive certain conditions. So Dr. Francis has already detailed that the transplantation can be autologous, wherein we use the stem cells from the patient, him or herself. So these are autologous hematopoietic stem cells. It could be mass sibling donor allogenic transplantation. When you say allogenic transplantation, you take the stem cells from the donor. It could be matched unrelated donor transplantation when you take the stem cells from a donor registry, or it can be partially matched or haploidentical transplantation, which are on the rise across the globe, as evident by a drop of fall in cord cell transplants across the globe, a rise in haploidentical bone marrow transplantation. And there can also be mismatched unrelated donor transplantation, wherein you do not have a partially matched or a haplo donor, you do not have a mass sibling donor. However, patient needs a transplant urgently, then you go for mismatched unrelated donor transplantation for certain these high risk malignancies. So autologous transplantation, what we do, patients has conditions like multiple myeloma, relapsed lymphoma, certain rare solid organ tumors, or rare refractory autoimmune conditions. So essentially, such patients are treated with therapy initially to get the disease into remission. Then you collect the stem cells and then give them high dose chemotherapy. So few things about autologous transplantation. In the true sense, autologous transplantation is not a transplantation at all, because there is no graft versus leukemia or graft versus host disease that occurs here. Essentially, what we use autologous transplantation is to facilitate very high dose of chemotherapy, which is myeloablative, and left to the patient after the therapy, he would then succumb to prolonged, persistent, severe neutropenia because of myeloablation. So to rescue or to facilitate such high dose therapy, we collect the stem cells before the conditioning therapy is given, and after the conditioning therapy goes in, those autologous stem cells are given to repopulate bone marrow and rescue patients from the myeloablative effect of the conditioning therapy. So here we bank on the myeloablative effect or the cell kill effect of the high dose chemotherapy, rather than the immune effect of graft versus host, graft versus leukemia effect. That is the idea of autologous transplantation. Whereas in allogenic bone marrow transplantation, done for certain conditions like acute myeloblastic leukemia, hemoglobinopathies like thalassemia, sickle cell disease. So what we want to do here is repopulate the diseased bone marrow with the stem cells from a donor. It could be any of the donor that we have just now seen. It could be a sibling, it could be a haploidentical, or it could be a matched unrelated donor. So here, because you're using the stem cells, the hematopoietic stem cells from a donor, there are increased risks of graft failure, of graft versus host disease. However, there are also added benefits of immune effect of graft versus leukemia or graft versus lymphoma effect, both of which are largely T cell derived. And also, what is T cell derived is graft versus host disease. So we'll discuss a little bit about it. So the most common indication across the world for an autologous bone marrow transplantation is multiple myeloma, relapsed Hodgkin's and non-Hodgkin's lymphoma, certain autoimmune disorders, and solid organ tumors. That is true across the globe. And the most commonest indications for allogeneic bone marrow transplantation are acute myeloblastic leukemia, acute lymphoblastic leukemia, MDS, MP, and overlap syndromes, and severe aplastic anemia. Whereas in children, it is likely to be one-third of the transplants are for hemoglobinopathies like thalassemia major, sickle beta thalassemia, and sickle cell disease. So what you do in transplantation is the host of steps essentially. So you will have to mobilize the stem cells. Like Dr. Francis was saying, previously all the stem cells were collected from the bone marrow, hence it was termed as bone marrow transplantation. However, now majority of transplantations done for hematological malignancies, the stem cells are collected from the peripheral blood. They're either mobilized by GCSF or GCSF with plerixafor or rarely chemo GCSF mobilization. So depending on what the conditioning is, oftentimes those cells are cryopreserved, either dump freezing or graded freezing. Then we use various conditioning therapies to both myeloablate and immunoablate the recipient in allogeneic transplantation. And then we reinfuse the cells. And the important thing to learn and remember is there will be about 2 to 3 weeks of extreme neutropenia, severe thrombocytopenia and anemia in some patients. There will be mucositis. There will be breach of all immune barriers, which makes this patient very susceptible for host of complications, including viral reactivation, bacterial infections, bad mucositis, poor nutrition, dyselectrolytemia, and that is a phase that these patients need to be closely monitored for, supported for, transfused to keep them safe. So bone marrow transplantation is not the work of a hemato-oncologist alone. You typically say it takes a village to care for a bone marrow transplantation patient, and you have to have evolved systems of laboratory medicine, a robust blood bank with apheresis, with cryopreservation facilities, with blood radiation, like Dr. Francis was mentioning, HL or immunology laboratory, and then other evolved systems if and when you need help. So this is the apheresis I think Dr. Francis has already told. So once you collect, this is our person who helps us for several years. You collect the stem cells from the peripheral apheresis and then you enumerate them. We know that we need about 2 to 5 million cells per kg at least for a safe engraftment. Any cells more than 2 to 5 are deemed safer. In autologous transplantation, oftentimes you use more. And in partially matched or haploidentical transplantation, you might want to use more cells just to facilitate engraftment. We also continue to use bone marrow harvest for patients who have non-hematological malignancies like thalassemia, inherited marrow failure syndromes in young children, where the idea is replace a failed marrow. Here you don't need graft versus host disease. I think Dr. Francis again had put the qualitative difference between a marrow harvest and a peripheral T cell apheresis harvest. One of the important distinction between the two is that the T cell load in a peripherally GCSF mobilized harvest is much more, which means the engraftment is robust and early in peripherally collected stem cells. However, there is a remarkable increase in graft versus host disease. So for disorders where you do not need graft versus leukemia or graft versus lymphoma effect, it might be good idea to use a marrow harvest wherein the T cell load is less, hence the risks of GVHD are less. But also be mindful that when you use a marrow harvest, the engraftment might be delayed by few days, and there is some increased risk of infection at least. So conditioning therapy, like we were discussing, can be extremely myeloablative. The conventional conditioning protocols had ablative dose of radiation, busulfan, cyclophosphamide. So the two most classically used myeloablative protocols were Cy-TBI with 12-gray TBI for acute lymphoblastic leukemia, and BuCy or busulfan with cyclophosphamide for acute myeloblastic leukemia. Now, we don't use these conditioning protocols for all patients, certainly, because when you use very intense myeloablative conditioning protocol, there are both severe hematologic myelosuppressive side effects, and also there are many non-medullary or non-hematotoxicities like VOD, veno-occlusive disease, pulmonary toxicity, cardiotoxicity, and that can lead to increased therapy or regimen-related toxicity and increased transplantation-related mortality, which is mortality within 100 days of transplantation. So we only use myeloablative conditioning when it is absolutely necessary. There are various studies which are looked at patients who have MRD positive hematological malignancy before transplant, compare them to MRD negative, those patients who are in deeper remission when they undergo transplantation. What is the utility of these protocols? So without complicating the matter, if I have to simplify, if the patient is young and fit, had a high risk disease, and if he's MRD positive, it is absolutely imperative to try and use the myeloablative conditioning to improve the risk of that, to improve the probability of long-term cure. It comes at a cost of increasing short-term toxicity. On the contrary, if the patient is frail, has a good deep remission with MRD negative disease, it might be a good idea to use reduced intensity conditioning to reduce the therapy-related toxicity, to reduce the risk of transplantation-related mortality, and yet preserve the long-term survival rate. So that is where the field is moving. So other question people always ask is whether, because we call it bone marrow transplantation, do we infuse the cells as a surgery? That is not true. I think the stem cell infusion, it is important for everybody to know, is given like a blood transfusion, just that the CD34 positive stem cells will home into the bone marrow and engraft and repopulate the bone marrow. So engraftment is divided to neutrophilic engraftment, which is absolute neutrophil count more than 500, and the platelet engraftment has various definitions, but essentially more than 20 to 30,000 without the need for the platelet transfusion for 3 to 7 days. So post-transplantation in allogenic bone marrow transplantation, it is very important to use the GVHD prophylaxis medications. And conventionally, for a mass sibling donor, most centers use the combination of methotrexate with cyclosporine or methotrexate with tacrolimus. There is no one protocol superior to the other. Depends on the institutional policies, depends on whether you have therapeutic drug monitoring systems in your hospital. There is some data to suggest that methotrexate with tacrolimus perhaps is at least as effective as methotrexate cyclosporine and maybe a little less toxic, but any of those protocols are totally justifiable to be used. What is also important to learn is one of the platform of transplantation which led to an explosive or exponential increase in the partially matched or haploidentical transplantation is a platform called as PTCY in a T replete transplant, wherein you use on the day +3, day +4 transplant post-transplant cyclophosphamide infusion, which has made the usage of partially matched or haploidentical transplantation easy for most patients, which means almost every patient who has a sibling is likely to have a potential donor, because all of us, as you know, we inherit one HLA haplotype from father, one HLA haplotype from mother. So the probability of sibling being a full match is 1 in 4, which is 25%, whereas almost everybody is a half match or a haplotype, which means every patient who needs a transplant would potentially have a donor in the family when we do the haploidentical transplantation. So with this post-transplantation cyclophosphamide platform, even if you do not have the cell sorter or graft manipulating techniques available in your country, one can safely consider doing haploidentical transplantation with this post-transplantation cyclophosphamide administered on day +3 and day +4, followed by tacrolimus and MMF, mycophenolate, which is given up to 45 days, and then the tacrolimus is continued up to 180 days, depending on any evidence or sign of GVHD. That is something for us to remember. So post-transplant, we'll have to monitor for the health of the graft, and it is typically done by chimerism studies. We all know what a chimera is. So essentially, depending on whether the transplant was a gender matched transplant or a gender mismatched transplant, various ways can be used to monitor a graft. So if it is a gender matched transplant, then we have to have a baseline chimerism studies to look at the single trinucleotide repeats of both donor and recipient, which is a genetic signature. And then the post-transplant one can look at these STR repeats and then find out what percentage are recipients and what percentage are donor. However, if it is a gender mismatched transplant, then one can simply use the FISH for XX and XY platform to look at the donor recipient cells for post-transplant monitoring, because depending on whether the patient has achieved a complete donor chimerism, a mixed donor chimerism, or a dropping donor chimerism, one we have to do various immune modulation treatment post-transplant. Graft-versus-host disease, I think briefly has been touched. So previously we used to classify them into a classic, acute graft-versus-host disease, which was any GVHD occurring within 100 days. Most notably, it included the GVHD of the gut, of the liver, and the skin. And if it was a severe acute GVHD of the gut, the outcomes are very dismal. However, now we know the time frame alone is not important, but rather the pathophysiology and true clinical manifestation. So it can be a classic acute, it can be a classic chronic, it can be a chronic overlap, or it can be de novo late acute, it can be recurrent late acute, or it can be a persistent late acute. So we don't look at the time frame as a watershed line these days, but look at the typical clinical manifestations, the pathophysiology, and how the patient presents rather than the time frames alone. So GVHD is an important complication, can account to about 10 to 20% mortality, in fact, depending on what was the HLA disparity, what were the other risk factors involved, and that most of these patients are then classified into either steroid responsive GVHD or steroid refractory GVHD. Of course, the treatment of GVHD itself has evolved, and we have various newer ways, both in terms of GVHD prophylaxis protocols and then in terms of GVHD treatment protocols as a first line, second line, and in steroid refractory late lines for the GVHD. And I must tell you, GVHD free, relapse free survivals for many of these patients has improved quite dramatically with the availability of newer agents for GVHD treatment. This is another question, people ask ABO incompatible transplantation. So again, we must know that the ABO incompatibility itself is not a contraindication for transplant. There can be a major incompatibility wherein the recipient has a preformed donor antibodies. For example, if the recipient is O and the donor is A or B, the recipient has preformed anti-A or anti-B antibody. So even if there is a major incompatibility, minor incompatibility, or bidirectional incompatibility, transplantation can be done safely. There can be some hemolysis, there can be some patients developing pure red cell aplasia post-transplant. However, these are not contraindications for transplant. That is something for us to remember. So a few slides on our center. We have been transplanting for several years. This is one of the first centers in southern part of India. We transplant for both pediatric and adult patients. It is important to know that you can have a transplantation without the transplant physician, but you cannot have one without a robust nursing team. They are the heart of transplantation, and their commitment and dedications are extremely important for the transplantation patients. So we transplant across the board for all disease, benign and malignant, thalassemias, PRCs, aplastic anemias, MDS, and our common indications for autologous transplantation are plasma cell dyscrasias and lymphomas. And for allogenic in pediatric, at least 1/3 to 1/4, they are for the thalassemias and sickle cell disorders, whereas in adults it is acute myeloblastic leukemia and ALL, which are the commonest indication. So I think these are the slides stating the same. And as you can see in allogenic transplantation, it is thalassemia, acute myeloblastic leukemia, and ALL. Those are the common indications. Now we are one of the state-of-the-art BMT. We have all services in-house, and we are extremely experienced. We are one of the first few to start haploidentical transplantation. And those patients who do not have a matched donor or any donor available, we can then get the cells from many of these international donor registries. Another point that I would like to make note of is previously we were to search in each of these individual donor registries. Now all of those are interconnected in the database. So even if you search in any of the donor registry, those registries will tell you if there is a potential donor and where that potential donor is, which donor registry that donor belongs to, so that it is easier for us to look at it. I think that is about the transplantation. Now, there are certain patients who cannot get to a transplant, or they are refractory to everything, or they are simply not fit for transplant. However, they have a disease which would need an immune effect or a transplant. So what do we do in such patients, or patients who have had a post-transplant relapse? I think what is really exciting is what is called as chimeric antigen receptor therapy, or CAR T cell therapy. So what is a CAR T cell? CAR T cell is a chimeric antigen receptor T cell, which is patient's own T cell, which is what an autologous CAR T is, and that has been genetically engineered to recognize and attack and kill cancer cells. Right? That sounds exciting. So what we know is it is like a chimera that we were talking about. So here what the chimera of a CAR T cell is that it has a tumor binding antigen domain, which is a part of B cell, right? And then it has a fusion protein having a T cell co-stimulatory receptor and a signaling domain. So if it is a BCMA CAR, then it attacks the BCMA on the myeloma cells and then kills it, right? So T cell usually do not have antigen binding specificity. B cells do not have the intracellular machinery of cytotoxicity. So the CAR T cell combines this antigen binding specificity of a B cell and intracellular machinery of a T cell to kill the cancer cells, which is why those are called as chimeric antigen receptor T cells. So how are they different from the native cytotoxic T cells that we have as an immune system? So this is an CAR is an artificial antigen receptor that mediates antibody targeted recognition. Most important thing to understand is the CAR mediated killing of tumor cell is not HLA restricted, right? So binding between CAR and its antigen tumor cell triggers a signal transduction cascade that leads to activation of T cell and it kills the target cell. So that is why it effectively creates a graft versus tumor effect without the risk of graft versus host disease, because this graft versus tumor effect is specific and is antigen recognized. Okay, so if you look at the normal T cell mediated tumor killing, so there has to be an antigen presenting cell to the T cell, which has to be MHC class 1 associated. And many cancer cells become smarter, they downregulate MHC class 1 expression, thus evading the T cell mediated destruction. Whereas the CAR T cell actually it bypasses the MHC recognition and it directly attacks the cells based on the antigen. So these cells are genetically modified. They are HLA independent, so they recognize the tumor directly without the need for MHC associated antigen presentation. They are very potent, leads to urgent activation and T cell CAR T cell expansion. They are effective even if the tumor downregulates MHC or other co-stimulatory molecules simply because they are not MHC restricted. That is very important to remember and understand. And it also overcomes the presence or lack of antigen presentation and tumor heterogeneity. So it has strong graft versus tumor effect without any risk of graft versus host disease and can be engineered to a specific tumor antigen. So most common CAR T cells that we have across the globe and even in India are CD19 CAR T cells for acute lymphoblastic leukemia, lymphomas, both aggressive lymphomas and indolent lymphomas, BCMA CARs for multiple myeloma. However, I'm sure there are multiple CARs in pipeline, so that is the advantage of CAR T cells. So this is the structure of CARs. Essentially, there is a chimeric antigen receptor. There's an extracellular domain which has variable light and heavy chains connected by a linker. There is a transmembrane domain which anchors the CAR receptor to the T cell membrane, and then there is an intracellular domain which is derived from the TCR signaling components. There are also co-stimulatory signaling domains to enhance the CAR T cell activation, proliferation, and persistence. So the initial CARs did not have the co-stimulator domain, hence the CAR persistence was minimal. However, the addition of co-stimulatory signaling domains has enhanced the CAR T cell proliferation, persistence, and activation. So we have discussed about it. The standard immune failure is because of downregulation of MHC receptor, need for the MHC receptor associated presentation of the tumor antigen. However, the engineered CAR T cells can lead to direct attack and cell kill. So, the initial first T cell antibodies were conceptualized between in the 90s or late 80s. However, once the CAR breakthrough has happened, there has been a phenomenal rise in the usage of CAR cells, and there are various types of CARs, the generation 1, generation 2, which is what we have been using across the globe. And then there are other concepts of making these CARs better, more effective, and less toxic. So this is what is done typically. So you do the leukapheresis for the autologous CAR T cell construct. And once you have those leukapheresis T cells, you send them across to the CAR construct team. They isolate and activate the T cell, and then the CAR gene is constructed, which is then transduced into the T cell with the help of a lentiviral vector or other viral vectors. And then such T cells which are genetically modified with the CAR gene are expanded as CAR T cells. and the same CAR-T product is then sent back to the center, and we infuse them into the patient. So that is the simplistic way of understanding. So first we'll have to design a CAR depending on which antigen you want to target, synthesize the CAR gene, and then insert that into a viral vector to be able to transduce the activated T cells. So once the T cells are transduced with the virus containing the vector, then you expand those T cells and send them back to the center. So that is how the CAR T are constructed. So the current approved CARs, like I mentioned, was CD19 CAR for ALL, DLBCL, indolent lymphomas, and mantle lymphoma, whereas the BCMA CAR is for relapsed refractory multiple myeloma. And we all know there is increasing mountain of data wherein these immune therapies are being used sooner than the later lines. So CD19 cars and the BCMA cars are the ones that are commonly used. So, and if you see, and we have used it in certain patients, the response rates are remarkable. The ease of administration is very, very easy compared to the conditioning therapy that we use in transplants. Essentially, we use the combination of fludarabine and cyclophosphamide for about 3 days, which is not very myelosuppressive, just enough immunosuppression to be able to facilitate the CAR proliferation, CAR activation, and CAR persistence. So that is the living drug that is very exciting and extremely effective even in patients who are having relapsed refractory disease, are CAR fit but not transplant fit. Not that these are like infusing vitamins, they do have certain toxicities. So most common acute toxicities after CAR infusion are what you call as CRS, cytokine release syndrome, ICANS, immune effector cell associated neurotoxicity syndrome, cytopenias like HLH, cardopenia, B cell aplasia, and hypogammaglobulinemia is almost universal because the CD19 mediated CAR effectiveness is such. Tumor lysis syndrome is rare, however, needs to be monitored for. So the late phase toxicity are persistent cytopenias, persistent B cell aplasia, immune deficiencies because of T cell fatigue, T cell deficiency. Infections are the commonest complications. One needs to make sure these patients are on antimicrobial prophylaxis. Their immunoglobulins are looked at. Intravenous immunoglobulins are administered if and when necessary. Delayed CRS and neurotoxicity are rare but can happen. And of course, late toxicity of secondary malignancy, impairment of quality of life, fatigue, memory issues are very well described with CAR T cells too. So CRS is common. It depends on the type of the CAR, the tumor burden before the bridging therapy used. So essentially mediated by the release of interleukin-6, interferon gamma, and TNF alpha. Most of the CRS occurs in the first week, and the patients may present with hyperinflammatory response syndrome like fever, chills, rigor, hypotension, rarely depending on the severity. Most of these patients are treated symptomatically in the ward. However, if they have hypotension or severe CRS, they may need moving to the ICUs, and tocilizumab steroids are used depending on the severity. ICANS is one of the feared complication. Should be diagnosed early. Some of these patients are on seizure prophylaxis. Steroids have to be administered for a potential ICANS, and it is very important to diagnose them early. So you actually have to use a mini mental scoring system so that you don't miss patients having early ICANS. So I think we have discussed. These are some of the transplant patients that I just would want to discuss. This was a 7-month-old boy who came to us about, I think, 10, 15 years before, had a bad viscotic syndrome, had a transplant back in April 26, and then he's a big boy now. So this was the Iraqi patient, had a refractory AML really back in 2016. I think he had IC bleed, came with hypolieukocytosis, leukostasis. He was told in his country that he cannot survive for weeks. However, he anyway came to our center, had a sibling, did a HLA matching that was not matching at all. We had to initially stabilize him, give him intense therapy to put him back into remission. We ourselves were not hopeful, but the spirit of the patient was such. We looked for a donor back in 2016-17. We had a donor in German donor registry, had a transplant, and recently, he came back and met me. He's doing well. So it is very gratifying, and such patients inspire us. This was a patient, I think he was a driver in one of the Middle East countries, was told to go back to his country because he had evolved into a blast crisis of chronic myeloblastic leukemia. Then I think those are the few days where the generic dasatinib had become available in our country. So he was treated with TKI based salvage therapy, had a transplant, and has gone back to his country. So I think this is one of our patient recently had a relapsed refractory lymphoma, underwent salvage therapy followed by an autologous transplantation. She's I think about 2 years post-transplant. So these are the patients. The idea of sharing is just to inspire all of us to work harder at this. This was a young girl from Sri Lanka, really had a refractory AML, had a haplodonor. However, she had a very high donor-specific antibody. Again, Dr. Francis was talking to all of us about the desensitization protocol. So such patients who have no other donor, who has a very high donor-specific antibody, it becomes very important to do the desensitization before transplant. Otherwise, if they have a DSA more than 5,000 MFI, it becomes very risky to do a transplant without desensitization, because then the risk of graft failure is extremely high. So this patient was given the desensitization protocol. So recently when I went to Sri Lanka, she is now all grown and back into her school and college. So I think that is why it is important that we stay true to the best possible ways of treatment, and then think deeply about each of these patients, do the best we can, because no matter how bad the disease is, some of these patients can still be rescued with all the treatment modalities that we have. So I think we are already a little late. It's about 8:50, so I stop here and would be happy to take any questions. It is important to know that the transplantation needs a big team. We have a bigger team. I don't have many of the pictures, but thank you all for kind attention. And hopefully, if there are any questions, I can take it. So I stop my presentation here and hand over the podium back to the organizing team. Thank you again.
Thank you so much. Thank you so much, Dr. Karashetty. We cannot thank you enough. Without wasting time, we are 20 minutes past 6 p.m. here in Uganda. Allow me invite the Uganda Medical Association CPD Chair, Dr. Henry Sechanzi, to give us a word or two. Then after that, we shall open the question and answer session for members here to ask their questions. For those who can type in the chat, kindly do. And for those that want to raise hands after Dr. Sechanzi's information, you shall raise your hands and ask questions. You're so much welcome, Dr. Henry.
Thank you very much. I hope I'm audible. Can you confirm if you can hear me?
Yes, Dr. Henry, you are.
Good. So, distinguished colleagues, ladies and gentlemen, good evening to you all, and welcome to this CPD session. It has been a great session. Personally, I've had a lot to learn from the presenters, Dr. Sally and Dr. Kaleshiti. It's really been a lot of good hematology to learn, and I believe all the people who have attended this have had something to learn. So, on behalf of the Uganda Medical Association, I want to thank you all for fixing some time out of your very busy schedules to be part of this. I want to thank you very much for always making time and attending these sessions. And especially, I want to thank our presenters, Dr. Sally and Dr. Kaleshiti, for the great presentation that you've made, as well as Dr. Drake for the wonderful moderation. And especially, I want to thank our partners, the Manpower Hospitals. Thank you very much for supporting these sessions. So we shall at least have one session per month led by Manpower Hospitals. And I think that will be the very first Wednesday of every month. So let's gear up ourselves for this. And if you think there are any topics that you think Manpower Hospital can lead us on, please go ahead and share with us so that we prepare ahead of time. I also encourage us to register for the CPD points using the links that have been shared. I noticed that some people just attend and they don't register. So that becomes really difficult for us to track and see who has attended when you've not registered. So if you've attended this session, please register. And those of you who are okay to be contacted directly by Manpower Hospital, please share your email addresses and your phone numbers. I put that provision in that link which I shared with you. I also want to remind all of us to ensure that we become members of the Uganda Medical Association, at least by the end of the year, because we're really trying to, we shall only award, much as whoever attends these sessions gets their CPD points recorded, but you only accredit for those who have subscribed to U.M.A. So please make sure that you try and subscribe to U.M.A. so that you'll be in good standing and you won't find any challenges when it comes to your license registration. For now, I think that's all I can say. I just want to end by thanking you all for making it to this session, and special thanks to our presenters for the great work that you've done. We shall be letting you know when the next session will be. Otherwise, that's what I can say for now. Thank you all and have a good evening.
Yes, thank you so much, Dr. Henry. Yeah, for those asking in the chat that they are subscribed members but haven't received their points, colleagues, just be sure that the points will come. We are now into question and answer session. Kindly put up your hand or put in the chat if you have any questions to our presenters this evening, Dr. Karashetty and Dr. Tsai. Yeah, I'm here monitoring. If you have any questions, kindly put your hand up or put in the chat. I know there is a lot of learning that has happened here. As following up in our WhatsApp groups, people are appreciating that they have learned, having had very new terms in their many years of medical practice. And yeah, that shows that they have really taken a point home. In case of any questions, I'm giving you about 2 minutes. If there is none, then we shall see what next. You put up your hand or put your question in the chat and I'll be able to read it out. For now, I'm not seeing any. It could also be possible that science means that people have understood, or it can also be the other way around. Galaxy A16, I see your microphone unmuted. I do not know if you want to ask any question to our presenters. We do have one more minute to go.
Yes, Dr. Drake, I see there are some questions in the chat. As much as they have been responded to, I don't know if our presenters would maybe want to add something to them. I thought somebody was asking, let me just see, but there were some questions in the chat. So I don't know if our presenters would want maybe to just speak about them.
Okay, yes, there is a question about how long GVHD could go on after treatment for sickle cell, and Dr. Sari responded to it. But as you've said, in case there is more information that you would want to allay, then he's welcome. If it's not there, Dr. Sari, I don't know if you want to say something about that.
Yes, thank you very much. I think overall the duration of the prophylaxis against GVHD, one depends on the stem cell source. As I said, if you did a cord blood, you like to have it for a shorter period of time. If there was in the conditioning, if the conditioning included, there is another immunosuppressant, it's called Pampas or aletuzumab. It is a monoclonal antibody against CD53. It tends to be quite immunosuppressive, and it tends to be a very good part of the conditioning that reduces the risk for GVHD. Or if there was any ex vivo graft manipulation, for instance, in some conditioning protocols, there's selective removal of the naive T cells, the T cells which are actually responsible for doing the GVHD. So if that is done, then usually the duration of the prophylaxis against GVHD may be even shorter than 6 months. But if someone has not had any GVHD, acute or chronic, and the full match, usually by 6 months, the tapering of the immunosuppression it already starts. But it can take longer if the patient had some GVHD, especially if they have chronic GVHD. Maybe Dr. Kalasheti might add on.
All right, thank you so much. Yes, thank you so much, Dr. Sari. Yeah, maybe if Dr. Kalasheti wants to add on.
No, I think I agree. I agree with Dr. Francis, really. So essentially, you can't predict. So there are GVHDs which are grade 1 and 2. And if it's a very high risk acute myeloblastic leukemia, for example, I would be worried more about the relapse than about trying to treat them with systemic therapy. However, there are some patients where the GVHD itself becomes an imminent threat to the life. Grade 3, 4 GVHD, bad acute gut GVHD, wherein we'll have to throw the kitchen sink sometimes. You start with hydrosteroid, and then patient has a steroid refractory steroid suboptimal response, then you do ruxolitinib, now you do belumosudil, you have ATG, you have a host of other agents. So nobody can predict what is the duration, but like Dr. Francis was mentioning, every transplantation has a conditioning protocol and a set GVHD prophylaxis protocol, and we must follow the protocol to the T, and we can't change the platforms and protocols. So if it's a mass sibling donor transplant, typically the PT, the post-transplant GVHD prophylaxis is a combination of methotrexate, cyclosporin, or tacrolimus. If it's a haplo transplant, we use post-transplant cyclophosphamide with TAC and MMF. And in mismatched transplantation or matched unrelated donor transplantation, serotherapy with ATG becomes extremely important. And all of these the protocols have their own inherent risks. PTCY might delay the engraftment. Lot of ATG can lead to increased EBV related PT LD disorders and EBV reactivation. A lot of steroids will lead to CMV reactivation. So it is very difficult to predict how a patient is going to behave.
Well, thank you so much. Thank you so much, Dr. Kalasheti. With your 10 plus years of experience in bone marrow transplant, here is a question from Dr. Nicholas Higenyi, asking about the 5-year survival rate for patients that have undergone bone marrow transplantation and their quality of life post-treatment. Thank you.
Again, apples and oranges really. So the 5-year survival typically again depends on what kind of transplant we offer. So for example, AML, intermediate or high risk, when you transplant in CR1 first remission, the 5-year survival rate is anywhere between 50 to 60% or 40 to 60%, depends on the age and comorbid illness and performance status. Whereas the same acute AML or ALL, when we transplant in CR2, when they relapse, depending on when they relapse, the 5-year survival rates are about 30 to 40%. If it is the thalassemia, so thalassemia-free survival post allogeneic transplantation is 80 to 90%. If it is aplastic anemia, low risk, less than 20 units of transfusion burden, patient is young and fit, the cure rates are much higher as against patients who are heavily pre-transfused, have failed an immunosuppression, have allo antibodies, where the risks of GVHD and TRM are higher. So we can't just give 5-year survival rates across the board, but largely for hematological malignancies, high risk leukemias, it is about 50 to 60% when done in CR1, lesser in CR2. For benign hematology, the outcomes are much better.
All right, thank you so much, Dr. Kalasheti. One more question. It can be either to you or Dr. Sari. What's your solution for the post-transplant patient who you have determined to have total rejection of the transplant? Dr. Kalasheti or Dr. Francis?
Yeah, I'm sorry, can you repeat the question, please?
The solution to a patient who has had total rejection to the transplant.
Yeah,
what can you do?
Very important question, really. So when we have, essentially the question is on the graft failure, right? So when you have the graft rejection, we divide them into primary graft failure, secondary graft failure. So primary graft failure is when the patient fails to engraft despite 25 to 50 days of observation, really. So most engraftments occur between day 14 to 21. Some delayed engraftments can stretch up to 25 to 30 days. Most of the neutrophil engraftment at least occurs within 14 to 21 days. So if the patient fails to engraft at all, which is termed as primary graft failure, then depending on what kind of conditioning that we have used, if we have used a myeloablative conditioning, such patient would need urgent second transplant. Now, sometimes patients who had non-myeloablative reduced intensity conditioning, there can be autologous reconstitution of the marrow. However, anyone who's had myeloablative conditioning would need an urgent second transplant, depending on the donor availability, how fit the patient is, whether he has a bad infection. Such second transplants will have to be done. And we know that when we do a second transplantation, at least we may have to give immunoablative fludarabine or some radiation to facilitate the engraftment of the second graft. So we have done second transplants. All the transplant centers who do the transplants in high volume will have about 3 to 5% graft failures in the transplant setting. So primary graft failure is extremely risky, needs second transplant. Now, some patients may have delayed graft failure, as evident by the chimerism assessment. So depending on how rapid the chimerism drops, really, and what is the underlying disease, we do various things. For example, if there was a full donor chimerism has started dropping, we worry about that being a harbinger of a relapse. So in such patients, number one, we taper down or stop the GVHD medications to facilitate engraftment. Some of these patients are given donor lymphocyte infusion. Some patients are given stem cell boost. So various ways and means are there, whereas the patient has a rapidly dropping graft and then becomes donor autologous reconstitution. Such patients, depending on how rapidly they need a transplant, one may have to decide about second transplant. So it depends on a host of issues, really, and primary graft failure is something that needs to be dealt with urgently.
Thank you so much, Karasheti. We have about 25 minutes to the top of the hour. I want to thank everyone who has taken his or her time amidst your busy schedules to be for this session. As we come to an end, I would like to have your parting shots from Dr. Karasheti. Then after that, we shall have parting shots from Dr. Sari, and then we shall have this session closed.
So first of all, thank you for this opportunity. I must congratulate Dr. Francis for wonderful presentation. Really, he covered the basics very well, and the Uganda Medical Association for this wonderful opportunity. I see a lot of people have joined in. I hope at least few concepts are clear about transplant, about CAR T-cell therapy, about GVHD, and host of other issues. I will request our team to keep in touch with all of you if there are any doubts, if we can help in any way. It is also very exciting to see Dr. Francis was mentioning and showing his transplant program, which is coming up, and that they're also already studying the gene therapy, which is extremely heartening. I'm sure patients will benefit immensely when the facilities start at home, and I hope, pray, and wish you all the very best. And I hope every patient who deserves or needs a transplant has an access to get to a transplant. Thank you.
Thank you so much. Thank you once again, Dr. Karasheti. Let's receive parting shots from Dr. Francis.
Yeah, I would also like to thank Dr. Karasheti for the the exposure he did on the bone marrow transplant. Really, it is not as mystical as many people think. People think that one has to have surgery to receive the transplant, but as you've heard, it is an infusion like any other blood transfusion. The only issue is that there's some preparation to be done and also very meticulous follow-up to be done. So we look forward to our patients being able to receive this treatment. And also, I think if you are thinking that a patient may need a transplant, you should consider it early enough, because in some instances, if they have a lot of morbidity, then they may not really be eligible, or it may become very difficult. So thank you very much. And thank you, U.M.A, for organizing this session.
We are very glad to our presenters this evening for really taking your time and teaching us a lot of new things that we have learned this evening. And thank you so much once again, our attendees, for spending all this time to be with us. We are glad as Uganda Medical Association, and we shall let you know of when our next session will be. But as we have agreed, the first Wednesday of every month, we will be willing to have a guest speaker from Marrow Hospital, who are our partners, who have a lot to share with us. I've been your moderator, Dr. Drake Ajira, the CPD Secretary at U.M.A Akwale Region, and I want to wish everyone a good evening, or a good night, or a good afternoon, or a morning, depending on wherever you are. See you again next month. Thank you and bye.